Subcommittee will come to order a minute early, the record will show. Welcome to the Ways and Means Subcommittee on Health, hearing on promoting integrated and coordinated care for Medicare beneficiaries. It is my pleasure to welcome our four witnesses today as we continue our discussion on the Medicare program and the different integrated care delivery systems offered to our seniors, including those up for extension this year. The committee continues to look at ways to reform Medicare and improve the delivery of care for our seniors and people living with disabilities. I think this is a good place to start. It's looking at some of the lessons learned from smaller programs that have offered targeted, coordinated care to some of the most frail and sickest beneficiaries in our Medicare program. Today is a great opportunity for us to hear about some of the impediments to providing value-driven care for the population and hear solutions that not only benefit seniors but taxpayers as well. PACE, or the Program for All-Inclusive Care for the Elderly, is an integrated care program that provides hands-on long-term care and support to beneficiaries who need an institutional level of care but continue to live at home. Although this program offers seniors and their caregivers a great opportunity to stay in the community and receive the care they need, the criteria for entering a PACE organization remains very restrictive. Additionally, the regulatory and administrative burdens of operating a PACE facility can often make it difficult for PACE organizations to expand and grow to serve more beneficiaries. Another integrated care option for vulnerable seniors is the Special Needs Plans, or often called SNPs. Congress must act by the end of this year to reauthorize SNPs in order for seniors to continue to have access. Yet, we continue to find challenges surrounding care coordination and delivery in certain types of SNPs. Due to the lack of integration of benefits and administrative burden of offering a SNP plan, CareSource, a managed care plan offered in my district, has delayed offering SNP plans in their current form. While continuing to offer other insurance products that serve dual-eligible beneficiaries, CareSource finds the integrated model that they are using in northeastern Ohio to be a better, more effective, and more efficient model to serve dual-eligible beneficiaries, one that reduces provider burden and ensures that patient receives the care and support needed to meet their total health care needs. Today, we will hear from our panel of experts on the benefits and challenges to PACE and SNP operations, as well as its enrollees. We will also explore different bipartisan options for changes to these key programs and others within the Medicare Advantage space, such as value-based insurance design, that are needed to increase efficiencies, quality, beneficiary experience, and enrollment. As the Medicare population continues to grow, it is important that we continue to look at how we can move from volume to value-based across all parts of our Medicare program. Today, we will hear about how we can allow more plan flexibility within the MA space through incentivizing the use of high versus low value care, and have the potential to lead to lower costs for both taxpayers and beneficiaries while improving health and quality outcomes. I now yield to our distinguished ranking member, Mr. Levin, for the purposes of an opening statement.
Thank you very much, Mr. Chairman, for holding this hearing. I would like also, as you did, to thank our witnesses for joining us today. We have an impressive panel that has prepared a number of thoughtful comments and recommendations. I'm pleased to see that it includes a fellow Michigander. This hearing is about new models to coordinate and integrate care for Medicare beneficiaries, especially those who are dually eligible for Medicare and Medicaid. These 11 million Americans are among the most vulnerable members of our society. More than 40% are under 65 and live with disabilities, and many have very complex health care needs. In the past, we have had a bipartisan commitment to providing high-quality care for this population, and hopefully this will continue. Unfortunately, the recent actions of my Republican colleagues suggest that this may no longer be the case. Last month, the House passed an ACA repeal bill that would slash Medicaid by more than $800 billion over the next decade. And 2 weeks ago, President Trump proposed a budget that would further cut Medicaid by $600 billion. These cuts would have a major impact on the people who are the subject of this hearing. Cutting Medicaid will hurt those 11 million Medicare beneficiaries who are dually eligible for both programs and who depend on Medicaid to provide services and cover expenses that Medicare doesn't. For example, Medicaid reduces out-of-pocket costs for low-income beneficiaries and pays for important services that Medicare does not cover, including long-term care. Ending the ACA's Medicaid expansion and switching to per capita caps or block grants would shift health costs onto beneficiaries and leave many without Medicaid coverage at all. This will reduce access to care and put financial strain on low-income seniors and people with disabilities. I hope we spend time this afternoon discussing this important issue. We are also here to examine 3 specific models for delivering care to Medicare Advantage enrollees. Special needs plans are the most prominent of the models we will discuss today. Currently, nearly 2.3 million Americans receive coverage through these plans, which are tailored to the needs of specific populations of beneficiaries. Special needs plans are particularly important to those who are eligible for both Medicare and Medicaid. Authorization for the program, as you said, Mr. Chairman, expires next year, and I look forward to working in a bipartisan way on an extension that maintains quality while promoting better care and stronger protection for beneficiaries. We will also discuss PACE. This model has shown promising results by providing coordinated care to frail elderly populations. Although its footprint is small, PACE has allowed thousands of Americans to maintain their independence by providing nursing home level care in community settings. As we consider the future of this model, our focus must be on ensuring that quality remains high and that we do not sacrifice our standards in the interest of expansion. This is particularly important now that for-profit enterprises are eligible to participate in PACE. Both of these models, special need plans and PACE, help provide care for beneficiaries who rely not only on Medicare but also on Medicaid. Finally, we will discuss value-based insurance design, or VBID, a proposal to reduce healthcare costs by promoting high-value care. This model is in its infancy in Medicare, and we still need to learn more about its impacts on the program and on beneficiaries. To be a success, VBID must show meaningful improvements in efficiency without reducing access to necessary services. I hope to hear more from our witnesses, from all of you, about our options for this model moving forward. Once again, I thank the chairman and the panel for joining us, and I look forward to very constructive back and forth. Thank you, Mr. Chair.
Thank you, Mr. Levin. Without objection, other members' opening statements will be made part of the record. With that, I'd like to introduce today's witnesses. First, we'll hear from Ms. Gretchen Jacobson, Associate Director of the Program on Medicare Policy at the Kaiser Family Foundation. Thank you for joining us today. Next, we'll hear from Ms. Cheryl Wilson, Chief Executive Officer at St. Paul's Senior Services. I appreciate you traveling all the way from California to be with us. After Cheryl, we'll hear from Mr. David Grabowski, a professor at Harvard Medical School and recent MedPAC appointee. Congratulations, by the way, on that appointment. We look forward to working with you on other Medicare policies that come before this committee in the future as well. And last but not least, from what we in Ohio call the state up north, and from the school up north, Dr. Mark Vendrick from the University of Michigan. Is that your son behind you? Is he an Ohio State guy? Oh, I like that. Very good. I like that. Very good.
Say that again.
Michigan State. I like Michigan State. Dr. Vendrick is Director of Value-Based Insurance Design Center at the University of Michigan. He's also Professor of Internal Medicine at the School of Medicine and Professor of Health Management and Policy in the School of Public Health at the University of Michigan. He received his BA from the University of Pennsylvania, however. That's good. And his MD at the at Harvard Medical School. So welcome all of you. As you kind of notice, I'm in a little rush because we have to go vote. I think what we'll do now, if everyone agrees, we'll go vote, we'll come back, and then we'll hear from Ms. Jacobson and the rest of you shortly. Our hearing will resume, and we will get right to our witnesses. First up, Ms. Jacobson, again from the Kaiser Family Foundation. You're recognized for 5 minutes.
Mr. Chairman and members of the subcommittee, I am Dr. Gretchen Jacobson of the Kaiser Family Foundation. I am honored to be here this afternoon to testify on the topic of promoting integrated and coordinated care for Medicare beneficiaries. Over the years, the Medicare program has developed and continues to test new approaches for integrating and coordinating care for high-cost, high-need Medicare beneficiaries in both Medicare Advantage and traditional Medicare. My testimony today focuses on 3 of these approaches: special needs plans, the Program of All-Inclusive Care for the Elderly, or PACE, and value-based insurance design within Medicare Advantage. 2 of 3 of these approaches focus on people dually eligible for Medicare and Medicaid. The 11 million people who are dually eligible for Medicare and Medicaid comprise about 1 in 5 people on Medicare. And these include many of the sickest and frailest people on Medicare. While most dually eligible beneficiaries are in traditional Medicare, about 1/3 are in Medicare Advantage plans. This is a similar share to enrollment among other people on Medicare. Among dually eligible beneficiaries in Medicare Advantage plans, about half are in regular Medicare Advantage plans, and the other half are in special needs plans, or SNPs. SNP enrollment is limited to beneficiaries with specific health conditions or to beneficiaries dually eligible for Medicare and Medicaid. SNPs for dually eligible beneficiaries comprise the largest SNPs and include about 2 million beneficiaries in 2017. While SNPs have been part of the Medicare Advantage program for over a decade, we know little about what additional services or benefits enrollees receive, how well plans coordinate care for high-need enrollees, and the outcomes for high-need enrollees compared to other care options. Like SNPs, PACE programs also receive capitated payments from Medicare. PACE is a provider-based program that was established in the 1970s and is designed for people who need a nursing home level of care but want to continue living in their communities. The extensive literature on PACE suggests that it increases longevity, reduces nursing home care, and reduces hospitalizations and emergency room visits. The biggest challenge with PACE has been its scalability. Most PACE programs are relatively small. Value-based insurance design is another approach for improving the management of patient care in Medicare Advantage and traditional Medicare. Some have proposed using it to allow Medicare Advantage plans to enhance benefits for enrollees with specific health conditions. This would be a departure from current rules, which require Medicare Advantage plans to provide the same benefit package to all enrollees, regardless of their health conditions. This year, CMS began permitting Medicare Advantage plans to test a value-based insurance design model with specific chronic conditions. My full testimony raises several questions about value-based insurance design, the largest of which is who should really decide which providers and services should be designated as high value. Overall, it's critical to properly evaluate these programs not only because of the growing number of people in them, but also because many of the enrollees are some of the sickest and frailest people on Medicare. It's important to make sure delivery systems are supporting them rather than putting them at risk. Also, if the programs are shown to be effective, it is worth exploring how to broaden the programs to include other people in Medicare Advantage plans and traditional Medicare with high needs and high costs. Appropriately managing the care of high-cost, high-need Medicare beneficiaries, many of whom are dually eligible for Medicare and Medicaid, could help ensure the fiscal sustainability of both Medicare and Medicaid in the years to come. At the same time, it remains important to ensure that adequate protections are in place to retain access to healthcare services, providers, and quality of care for the sickest and poorest on Medicare. Thank you, Mr. Chairman. I would be happy to answer any questions, and I look forward to working with all members and staff of the subcommittee on these issues in the future.
Thank you, Ms. Jacobson. Ms. Wilson, you are recognized for 5 minutes.
Thank you. And good afternoon. Thank you, Mr. Chairman Tiberi and Ranking Member Levin, and other distinguished members of the subcommittee. I am Cheryl Wilson, Chief Executive Officer of St. Paul's Senior Services and St. Paul's PACE in beautiful sunny San Diego. I represent the National PACE Association here today and their 122 PACE organizations with 233 sites in 31 states, serving over 42,000 participants each day. So what is PACE? PACE is the gold standard for integrated care. PACE stands for the Program of All-Inclusive Care for the Elderly, a community-based health and social services provider which receives a capitated payment rate to serve a frail set of Medicare-eligible frail seniors, all of whom are at nursing home level of care but are still being cared for at home by the PACE team. We are an insurance company and the care provider. The average participant is 77 and lives with multiple chronic, very complex conditions limiting their activities of daily living. 50% have some form of dementia, but through PACE, 95% live at home. Even more challenging, at St. Paul's PACE, 50% of those we serve live at home all alone. Along with our PACE, St. Paul's Senior Services is a full-service, nonprofit organization established in 1960. We provide retirement homes, HUD housing, assisted living, memory care, day programs, skilled nursing, and now housing for homeless seniors. PACE keeps frail seniors in their homes and communities by providing timely, clinically appropriate treatments and social supports. PACE participants experience a high quality of life and optimal medical outcomes with lower costs. 2 weeks ago, I had lunch with a lady enrolled in our PACE program. She had all her belongings wrapped securely in a plastic bag. She told me her other stuff was outside, all wrapped up because of bugs. She shared with me her multiple major medical conditions and her inability to get out to grocery stores or to her doctors for visits. Thus, she had a history of visiting the emergency room every 2 to 3 months, which she hated because of the long waits, all the hubbub, and the fact that no one ever spoke to her, rather only about her and over her. She said she was getting to like the PACE staff, but it was taking time to believe that they could be so nice and really mean it. In fact, this participant had spent the first 3 weeks in PACE sitting outside the building, with care being delivered either to her at home or on the bench outside due to her paranoia and fear of exploitation. She finally agreed to have her home treated for bed bugs and other infestations, to receiving personal care and to having her belongings wrapped up until she was willing to give them up for 3 days of freezing, which was needed to eliminate all the infestations. In the meantime, this lady was provided with home care, home-delivered meals, daily home medications, twice weekly personal care at the PACE Center, weekly physician visits, social services, psychiatric interventions, and many other ancillary services. In the 4 months she's been with PACE, this lady has not experienced a single emergency room visit. In fact, a study we did showed that in the first year of PACE, patient hospital visits declined 73%. PACE serves many frail elders and individuals with disabilities today, but we could serve many more. The decades-old PACE regulations must be updated immediately. While CMS has issued a proposed rule, it is yet to issue the final rule. Similarly, CMS could support PACE growth by implementing the congressionally granted pilot authority to serve new populations with similar needs and medical complexities. We ask CMS to move the pilots forward quickly. Other steps forward are some statutory improvements to enable PACE to better serve Medicare beneficiaries. PACE has incorporated many of the reforms promoted by Medicare, including coordinated care and integrated financing. PACE has proven to be a good value to taxpayers. If you haven't visited, please go to visit a PACE site in your state, and if you don't have a PACE site, ask why. In all my years in healthcare, I know that PACE is the very best model of care as professed to me by Health and Human Services Secretary Tommy Thompson over 15 years ago. Thank you for listening to me, and I look forward to answering your questions.
Thank you. Mr. Grabowski, you're recognized for 5 minutes.
Great, thank you. Good afternoon. My name is David Grabowski, and I'm a professor in the Department of Healthcare Policy at Harvard Medical School. I would like to thank Chairman Tiberi, Ranking Member Levin, and the distinguished members of the committee for giving me this opportunity to speak today. This testimony is derived in large part from the academic work I have done related to integrated and coordinated care for Medicare beneficiaries. Before I begin my substantive remarks, I would like to emphasize that my comments reflect solely my beliefs and do not reflect the opinions of any organization I'm affiliated with, including MedPAC, to which I was just appointed to last month. Mr. Chairman, we all share the policy goal of coordinated, high-value care for dual-eligible and chronically ill Medicare beneficiaries. Under traditional Medicare fee-for-service, dual-eligible beneficiaries have 3 health insurance cards, Medicare, Part D, and Medicaid, and with 3 very different sets of benefits. Ultimately, this fragmented model of coverage does little to encourage cost containment or high-quality care. Under an integrated model of care, enrollees ideally have a single set of comprehensive benefits covering a range of services. They have an individualized care plan with a coordinated team of health providers that encourages care in less restrictive, lower-cost settings. Medicare Advantage Special Needs Plans, or SNPs as they are called, are one potential way to achieve this type of financial and clinical integration. SNPs were authorized in 2003 with the idea of attracting a different type of beneficiary into Medicare Advantage. Today, over 2 million individuals are enrolled in SNPs, which is greater than the number of Medicare beneficiaries in all other integrated care programs combined. SNPs enjoy some unique regulatory advantages. As such, it is vitally important that we understand whether there's anything truly special about special needs plans to justify their unique status. 2 areas where SNPs have the opportunity to provide benefits are through improved quality and better integration. In terms of quality, the research is somewhat mixed when comparing SNPs with traditional Medicare Advantage plans. The findings depend on the type of SNP. Institutional SNPs, or I-SNPs, perform better than other plans on the available quality measures. Dual-eligible, or D-SNPs, perform better when they are strongly integrated with Medicaid, but very similar to other plans when less well integrated. Finally, chronic condition SNPs, or C-SNPs, generally perform no better and often worse when compared to other plans. In terms of integration, if the dual-eligible SNPs are going to offer a truly integrated product, they need to both clinically and financially integrate with Medicaid. As a bit of history, the first generation of D-SNPs had little integration with Medicaid. Beginning in 2008, the D-SNPs were required to have a contract with Medicaid. In response, most D-SNPs simply established a contract for case management of Medicaid services. Today, most D-SNPs are still not at risk for Medicaid spending or accountable for Medicaid outcomes. This is not true integration. Moving forward, Mr. Chairman, I want to highlight 4 areas of opportunity for Medicare policy. First, all D-SNPs should be both clinically and financially integrated with Medicaid. Otherwise, it is hard to make a case for this model over regular MA plans. Second, SNPs must show that they offer higher quality to beneficiaries. If certain models like C-SNPs do not generally perform better than regular Medicare Advantage plans, we need to reconsider whether this model is working for beneficiaries. Third, payments to SNPs for those full duals should be commensurate with the cost of covering these individuals. Historically, risk adjustment is not properly accounted for the frailest beneficiaries. CMS recently adjusted payments upward for the full duals to address this issue. I would encourage continued oversight on the adequacy of payments and risk adjustment. Finally, relative to other models like PACE and the VBID demonstration, SNPs have not been comprehensively studied by CMS in over a decade. If we're going to continue to put public dollars into this program, we need a more rigorous and nuanced understanding of which SNP models work for which Medicare beneficiaries. In summary, the theory of integrated care underlying the SNPs is incredibly compelling. In practice, however, we have not achieved meaningful integration in the majority of SNPs to date. Reforms that encourage true integration will help ensure high-value care for our frailest Medicare beneficiaries. Thank you, Mr. Chairman. I look forward to your questions.
Thank you. And last but not least, the gentleman from up north, as we would say in Ohio, Dr. Vendrick, you're recognized for 5 minutes.
Good afternoon, and thank you, Chairman Tiberi, Ranking Member Levin, and members of the subcommittee. I am Mark Vendrick, a practicing primary care physician and a professor at the University of Michigan. Go Blue. Mr. Chairman, I applaud you for holding this hearing because access to quality health care and containing Medicare costs are among the most pressing issues for our national well-being and economic security. Moving Medicare Advantage from volume-driven to a value-based program requires a change in both how we pay for care and how we engage consumers to seek care. Yet, before today's hearing, little attention has been directed to how we can alter beneficiary behavior to make MA more effective and efficient. Today, I urge you to support the bipartisan effort to allow MA plans across the country to incorporate value-based insurance design to help members become better health care consumers. I could tell you with great confidence that my Medicare patients could care less how much the federal government spends on health care, but they do care deeply about the amount they have to pay out of pocket to get the care they need. With rare exception, MA plans implement cost sharing in a one-size-fits-all way, in that each beneficiary is charged the same amount for every doctor visit, every diagnostic test, and prescription drug. People ask me all the time whether the amount of cost sharing faced by MA members is too high or too low. The answer, as every clinician knows, is it depends. But asking MA members to pay more for all services, despite clear differences in clinical value, results in decreases in the use of essential care, the care I beg my patients to do. And this cost-related non-adherence negatively impacts our most vulnerable patient populations. So I see this blunt one-size-fits-all approach as penny-wise and pound-foolish. Does it make sense to you, Mr. Chairman, that my MA patients pay the same co-payment to see a cardiologist after a heart attack as to see a dermatologist for mild acne, or pay the same prescription drug copayment for a life-saving drug that treats diabetes, cancer, or depression as one that makes toenail fungus go away? Realizing that MA beneficiaries use too little high-value care and too much low-value care, I endorse a clinically nuanced cost-sharing approach as a potential solution. Clinically nuanced value-based insurance designs set consumer cost-sharing levels to encourage the use of high-value services and providers and discourage the use of low-value care. For the record, I support high cost-sharing levels, but only for those services that do not make MA beneficiaries any healthier. Led by the private sector, VBID is implemented by hundreds of public and private employers, several states, and will soon be incorporated into the TRICARE program. The integration of VBID into MA has garnered broad multi-stakeholder and rare bipartisan support. I would like to acknowledge subcommittee members Diane Black and Earl Blumenauer, whose bipartisan leadership on this issue led to the 2015 announcement of the MA VBID model test, a 5-year program that allows designated plans, now in 7 states, to reduce cost sharing for specific services and providers, but only for those beneficiaries with specified chronic conditions. In January of this year, 9 MA plans successfully launched disease-specific programs combined with enhanced benefits to help people manage their chronic diseases. Responding to interest from MA plans in other states, CMS added 3 more states to the demo starting next year. So due to the VBID success in the private sector, the TRICARE pilot, and nationwide interest in the MA VBID model test, bicameral, bipartisan legislation has recently been introduced to allow MA plans in all 50 states the flexibility to allow MA plans to set beneficiary cost-sharing levels on clinical value, not price, of medical services. It is my hope that the subcommittee supports the national expansion of VBID and MA, which when coupled with other promising integrated models like the PACE program discussed today, could result in healthier Medicare population, which motivates me as a physician, and more efficient federal expenditures, thus serving the best interests of American taxpayers and future beneficiaries. So it's my great pleasure to support the Medicare program, and I'm happy to work with the subcommittee further and look forward to hearing your comments and answering your questions. Thank you.
Thank you, Doc. Not bad for a Michigan guy.
Thank you.
Ms. Wilson, just a thought on the PACE program. I think we'd all agree that most most of us, as we age and become elderly, would prefer to remain in our homes as we age, and ensuring that Medicare beneficiaries have the option to safely stay in their homes along with the right support system is obviously important, but it often requires a dedicated caregiver who can help with household needs or transportation or meals. Caring for that elderly family or friend can be awfully difficult at times and can take a toll both mentally and physically and sometimes actually financially. Can you expand on that, comment on that, and give us your thoughts?
One of the challenges is to keep the person, the participant, the patient at home because that's where they want to be. But it is challenging. 95% of all PACE participants, however, do live at home, and that's across the country. The way that happens is because the interdisciplinary team meets on a daily basis, and the needs of that person at home are just as important as the medical conditions that are treated once they come into the clinic. So taking care of things at home, such as meals, house cleaning, grab rails in the bathroom so people don't fall, all of those things are very important. The social components of healthcare are just as important to save dollars on the healthcare side and to make keeping somebody at home efficient and effective is the key to PACE.
Mr. Grabowski and Ms. Jacobson, if you could comment on this. You specifically spent quite a bit of time in your testimony on the dual eligibles. Dual eligibles are auto-assigned Medicare prescription drug plans in several states, including my own state of Ohio, and they're allowed to auto-enroll dual-eligible beneficiaries with opt-out parameters in the D-SNP plan specifically. Can auto-assignment lead to higher beneficiary enrollment, in your opinion? And can auto-assignment be used as an incentive, maybe, to fully integrate their benefits in the D-SNPs?
Yeah, maybe I'll start. There was actually some early experience with auto-enrollment or passive enrollment in the SNPs. Several states actually had their beneficiaries. Texas would be an example, Arizona, Minnesota. About 50,000 beneficiaries were automatically or passively enrolled into the D-SNP. So there was some early experience that it actually worked. I think it can increase enrollment numbers. I'd be wary of saying it's going to get, and we'll get a broader selection of individuals in, so it gets around some of the risk selection issues that many of us have been so concerned about, that plans may be cherry picking or attracting certain types of beneficiaries. I would point, however, to the work we've done on the Financial Alignment Initiative, the CMS demonstrations for the duals. We looked at 8 states, and all of those 8 states use passive enrollment or auto-enrollment. And it turned out only about 25% of eligible duals stuck. So that means 75% opted out. You'll be happy to hear, Mr. Chairman, the state that did the best was Ohio, actually. Wow. Yeah, about 2/3 of beneficiaries remained in the dual demo. Ohio did a very clever thing by first enrolling individuals passively into Medicaid in a first stage, and then doing Medicare in a second stage. On the other end of the spectrum, New York had the lowest enrollment at 5%. There, they coupled their enrollment process with counseling and required each new beneficiary to actually go through counseling. That turned out to be a mistake, in that a lot of individuals didn't want to undertake the counseling and hence opted out of the program. Okay. So I guess passive enrollment will work to bring enrollees in. It'll bring in a more diverse group of enrollees. I think the challenge is that it won't get everyone. And I do think how you design the passive enrollment, the Ohio-New York difference, really matters. Thank you.
Jason?
I agree. And the financial alignment models do provide a precedent for this. There is, you do need to really consider, though, that more than half of dual eligibles have some sort of mental impairment or cognitive impairment. So it's really important to consider not only that they have a method of opting out, but also that they know about it and that they're aware of it. And this is very difficult when you're talking about a population with schizophrenia, Alzheimer's disease, and other mental illnesses, to make sure that they really understand that they have another option that they can go to.
Great point. Doc, you mentioned the CMS VBID demonstration, and in your opinion, if you could expand on, is that the demonstration is set up in a way that allows Medicare Advantage plans that the necessary flexibility for them to reach the full benefit of the VBIDs?
So that's a great question, and it's important to point out that, as mentioned in Dr. Jacobson's remarks, is that when Medicare was introduced in 1965, one of the foundations was this non-discrimination clause that every American in Medicare have the same benefit design. And as all clinicians and like Representative Black know, that medicine is unbelievably personalized and moving rapidly in that direction down to the level of the gene. So we have argued that people should be treated differently and given access to different care, most notably an eye exam, which should be more easily assessed by someone with diabetes than someone who doesn't. And it was quite a task, and I thank the subcommittee for the leadership to have this waiver be the first ever to allow a Medicare recipient with a specific condition to have a different benefit design than someone else, allowing precision medicine to be aligned with benefit design. So important step forward. 3 of the states that are expanding to next year are represented on this committee, and I think that there is movement afoot by CMMI to allow greater flexibility and uptake of these programs. Most notably, one is that the conditions are designated by CMMI. I think the plan should have a little bit more flexibility to decide which population should be available to have greater access to certain services and providers. I think that we should allow the plans to expand the services that they can reduce cost sharing for across the entire spectrum of care. And I think given that the fiscal responsibility that we must attend to with any changes in Medicare is, say, we can't always spend more and we often have to cut back. And given that most of the blunt instruments get people to use less of all care, I think it's important now for Medicare to walk very slowly and carefully into the area of reducing the hundreds of billions of dollars of Medicare expenditures that don't make one beneficiary any healthier. There is a new initiative called the Choosing Wisely program, which has launched over 40 clinical specialty societies, naming specific services that maybe we're doing too often and spending too much money on. So broader spectrum of services, more flexibility on the specific conditions, and start to pay attention to the fact that while the best part of the demo is making high-value services more accessible, to be fiscally responsible, we have to start thinking about clinically driven reduction of low-value care.
Thank you. With that, Mr. Levin is recognized.
Thank you, and again, welcome. Just a word on integration. As I look about us, the 4 of us Democrats on the committee at the time of ACA were in the vanguard of those who sought to have more integration, more bundling, all kinds of concepts. And some of that was built into ACA, in part, I think, because of the efforts of some of us here on the committee. Let me just say a word about the interaction between Medicare and Medicaid, because when we have been debating health care reform, there's been very little attention to that. So I'd like us, I guess, Ms. Jacobson, you referred to it and others might comment, just how important it is and the potential impact of reduction of Medicaid on dual eligibles and others who are in like positions. If you could, it can be complicated, but I think can also be stated rather clearly. Why don't you try? What's at stake when we talk about dramatic decreases in Medicaid as in the bill that passed here and then the president's proposal for an additional, $600 billion?
Okay. Like you said, this is a very complicated issue and could have a wide range of effects. One thing that that a per capita cap like that would do is it does lock in historic spending. So, for example, while it would adjust for the changes in the number of people who may be on the program, it would not necessarily adjust for the services that a state may want to provide to the people in the program. So, for example, if it would like to shift more people into community-based services, which seniors prefer, it may not have the financial flexibility to do so without cutting back on other benefits. It would be more of a trade-off financially for a lot of states because the mix of services they provide to some extent would be constrained. It would affect, most importantly to note, that 1 in 5 people on Medicare also receive benefits from Medicaid, most of whom received cost-sharing and full Medicaid benefits as well. So this would affect a significant share of people on Medicare.
Anybody else want to comment on that, Mr. Green?
Sure. I assume we'll talk a lot today about the adequacy of payments on the Medicare side of the SNPs. If we're not contributing enough on the Medicaid side, if there's shortfalls there, that's also going to lead to access problems, quality of care problems. And a lot of my research has suggested when you underfund Medicaid, that cost shifts causes spillovers to Medicare. So you underfund nursing home care or care in the home or the community. That leads to more Medicare finance hospitalizations for dually eligible individuals. So to think about these programs as being in their own silos is a mistake. For the dually eligible individuals, how we finance and deliver Medicaid services matters for Medicare spending and outcomes, and the opposite obviously is true as well. How we pay for and deliver Medicare services matter for Medicaid outcomes and spending. They're linked, and so you can't think about them separately. So any kind of cut in Medicaid will have impacts for the Medicare program as well for the dually eligibles.
Anybody else want to comment on that?
Medicaid pays about 65% of a PACE participant's capitated rate. And so Medicaid is a very important piece. I think each state will have to look deep into their souls and decide how those Medicare dollars are going to be expensed and to which populations, because there are many populations other than seniors who receive Medicaid funds. I think it's going to be a very difficult decision, and I think those of us who serve seniors will be faced with very difficult decisions, and I think we will have to be very creative because I don't see any of us wanting to cut back on any services for seniors going forward.
Thank you. Yield back.
Thank you. Before I recognize Mr. Roscom, I just want to remind members that we do not have jurisdiction, though we'd love to have jurisdiction in the Medicaid program. Mr. Walden and Dr. Burgess would not like that, so if we could kind of focus within our jurisdiction. With respect to that, Mr. Roscom is recognized for 5 minutes.
Thank you, Mr. Chairman. Admonition received. June is Alzheimer's and Brain Awareness Month, and it's no surprise to anybody on this panel the devastating nature of this disease. 6th leading killer in the U.S., 5 million Americans are suffering from it, and some folks suggest that it's the most expensive disease in the United States that people are suffering with. One of our colleagues, Representative Sanchez, and I have been working on legislation that would authorize a CMS demonstration in terms of a general approach on this. So that's all to say there's a lot of interest in how all these things have an interaction with Alzheimer's in particular. Dr. Jacobson, what's your insight or what's your perspective on how many Alzheimer's patients are enrolled in SNPs, and in your opinion, what are the benefits that these plans have for Alzheimer's patients and their families based on your experience?
We actually don't have the data on how many Alzheimer's patients are enrolled in SNPs. That's possibly something that we could look into, and I could get back to you or your staff after this hearing.
Okay, that would be helpful.
Yes. So we really don't know to what extent what additional services and benefits are being provided to all SNP enrollees, including people who have Alzheimer's. So it's really difficult to say what they're actually receiving that's helping them in the SNPs.
Okay. Anybody else have a perspective on that?
In PACE, 50% of our population has some form of dementia or Alzheimer's disease. And it's a challenge. It's truly a challenge. So moving forward, we need to deal with this. We are dealing with it very well in the PACE program right now. We're able to still keep those people at home. As I mentioned before, some of them are living alone at home. But it is something that we are seeing as a future problem as the population grows.
Okay.
Although we can't give you the exact number, there are undoubtedly a number of individuals with dementia in the different SNP models. I can say there are very few chronic condition SNPs focused just on dementia. The majority of those C-SNPs are focused on diabetes. I think just given the prevalence here, we actually need to do better across the board in dementia care. I don't think a specialized model is really the way forward. I would prefer to see all all Medicare Advantage plans get better at dementia care. That trying to build more specialized models, I don't think is the best path forward, just given the numbers you already cited.
Okay. Dr. Vendrick?
Briefly, just for the reasons that you state, Mr. Roscom, I was very pleased to see that not only were 3 states added to the VBID demo for 2018, but 2 conditions were added as well, which dementia was one. So we're very hopeful, since many of the states represented on this subcommittee are actually in those demo states, that the 7 original states in Michigan, Alabama, and Texas, all represented here, would talk to their Medicare Advantage plans to encourage them to step away from diabetes, heart disease, COPD, the more common conditions now in the current demo, and think outside the box and move to explore a VBID MA dementia model that would, I think, lead to the increases in care that you're looking for.
Okay. Thank you all. Thanks, Mr. Chairman. I yield back.
Ms. Sewell, you are recognized for 5 minutes.
Thank you, Mr. Chairman. Today we're talking a lot about saving costs and increasing value in the Medicare program. The reality is that we're not going to save costs in the long run if we don't improve outcomes. For our most vulnerable Medicare beneficiaries, especially our dual eligible, transportation barriers are often linked to poor outcomes. My office gets calls from seniors in my district who face both transportation and financial barriers to accessing basic health care services. Whether you're in an urban or a rural resident, if you are disabled and elderly with limited income and no access to a car or public transportation, even a few blocks can be the difference between you going to the doctor or not. My constituent, Eva, is 81 years old. She's dual eligible in Selma, my hometown, Selma, Alabama. She is diabetic, and when she has to go to the doctor, having no transportation, she really depends upon the neighborhood boys to drive her there. When Miss Eva's Social Security check doesn't make ends meet, she can't afford to pay the neighborhood boys to take her to the doctor, so she misses many appointments. In addition to diabetes, Miss Eva has a disease that doesn't allow her to cut her own toenails, a more advanced disease of diabetes. And so often, many times, she has to continue to have this very painful procedure done. She can't get it done at home because they're so afraid that something would go wrong with her diabetes. So she can't walk oftentimes. For diabetes, foot care cannot be ignored like this of Miss Eva. She often ends up at the emergency room having no transportation. Mr. Chairman, stories like Miss Eva's are more common than they are rare. This is not sustainable for patients or for the system as a whole. As I've said before, we aren't going to reduce costs until we improve outcomes. Had Miss Eva been enrolled in a plan that provided transportation services or had been educated on the resources available to her through non-emergency medical transportation, her emergency room visits would have been prevented. As you mentioned, Ms. Wilson, PACE organizations provide care in the home and transportation services to providers in the community. PACE organizations expand and improve on other services available, which are often inaccessible for frail and elderly populations like Miss Eva. The PACE program, however, is a very small program in my home state of Alabama, and in fact only services 200 Alabamians and is not available in Selma, Alabama, so Miss Eva cannot take part in it. My question is to you, Ms. Wilson. In your testimony, you talked about a story about a lady enrolled in your PACE program that may think of Miss Eva. I know that in California, you have access to a broader range of transportation than we do in Alabama. And my question is, do you believe that there are areas around the country where the program, PACE program, would not work, or where the program has not been successful? Likewise, what are the greatest barriers to expansion of the PACE program or special needs plans in rural communities like Selma?
Thank you for that example. That's very touching. Transportation is very definitely one of the greatest needs for our seniors because it isolates them. They can't get to the grocery store, they can't get to the laundromat, they can't get to the doctor, and emergency room visits are the response to that. So you're absolutely right. Transportation can be provided by PACE. Can PACE be provided in Selma? PACE can be provided anywhere.
So rural communities are not disadvantaged, even though when you look at where your programs are, where the PACE programs are, they're mostly in urban areas and not in rural communities.
There are quite a few in rural communities. It started as a pilot project under CMS, and they have been very successful. And most of those services are provided into the home with professionals going to the home because travel distances are a little bit longer than in urban areas. But still the services need to be provided, and they are provided more often by community service providers rather than PACE employees doing it in the center itself. So I would encourage you to encourage your state. Part of the problem is the difficulty in starting new programs, the cost, and the time frames to start new programs. And if we could all work with our state representatives and also with the CMS representatives to help speed up the process, there would be many more PACE programs across the country.
Thank you very much. I yield back.
Thank you. Mr. Smith is recognized for 5 minutes.
Thank you. Thank you to our witnesses here today, and certainly I appreciate the perspective. My colleague just raised some concerns about rural areas and perhaps the flexibility. I know that flexibility in general has afforded a lot of Americans within Medicare Advantage some options, and I think that is helpful, but it certainly hasn't really provided as many options for what I would say rural residents and then residents of very remote areas. And sometimes those services just are hard to come by, and whether it's Selma or whether it's ranch country in rural Nebraska, that there are some vast areas there that I hear, from various seniors, their concerns. But I'm just wondering if you would like to elaborate at all on what was already asked, or what other innovative ideas you might have, Mr. Grabowski, or Doctor, I guess it is, if you would care to elaborate.
Yeah, so I'll start by saying the special needs plans are national models, especially the institutional SNPs and the dual eligible SNPs are definitely in all markets. The chronic condition SNPs are largely concentrated in the South, but the point you raise is a good one. They're much more prevalent in urban relative to rural areas. I think there's two sets of explanations here. There's sort of supply side explanations and demand side, and I think a lot of us, there are a lot of stories like Ms. Eva where I do think there's a lot of demand for these models, and so I think I find that less compelling. I think it's more of a supply side story, whether it's kind of payment issues, regulatory, just the economics of trying to have a plan that's more diffuse in a rural area. So I do think that's an area, assuming the models meet the other criteria we've been talking about today, like fully integrated with Medicaid and all these other conditions, we definitely need to address this issue around rural areas.
Sure.
And I think your question brings up this point about extending healthcare coverage to a broader segment of healthcare services. As you can see in my testimony, the VBID-MA demo model focuses on high-value services, high-value providers, but we work very, very hard to include expansion of supplemental benefits. So I see patients like Ms. Eva every week, and if for some reason we figure out a way to get her medications or get her specialty visits, but she has no way to have transportation to them, the whole thing falls apart. So one of the more interesting aspects as the we hope the MA demo goes nationally, that instead of maybe saying that you should go to this hospital or use this medication, that maybe the demos will focus on these supplemental benefits like transportation and other types of services that may not be considered in the sweet spot of the realm of typical insurance designs.
Sure, thank you. Because I think there are a lot of great stories to tell about overall access and affordability within a fiscally responsible way. It's just that there are still some gaps out there. So if anyone else care to comment?
Yeah, I'll also comment that, in Medicare Advantage plans as a whole, the penetration rate in places like Nebraska is fairly low, and it's generally lower in more rural areas. So this really raises the question of, well, Medicare Advantage plans in certain models, like SNPs, have been pretty successful in proliferating in urban areas, but like you said, they really don't exist as much in rural areas. So it deserves some consideration of how to develop these models more broadly and make them more available perhaps to people in traditional Medicare as we learn more about what actual benefits help people.
Very well. Thank you. I yield back.
Ms. Chu, you're recognized for 5 minutes.
Ms. Wilson, I have visited my local PACE in Southern California, and I was so impressed by the level of care that was there. They have 2,300 participants. This is the program called Ultimed, and they have 2,300 participants through 8 centers in the greater Los Angeles area, 73% of which are dually eligible for Medicare and Medicaid. And I could see that these are some of the most vulnerable patients. The average enrollee has 9 separate medical diagnoses and has impairments in 4 activities of daily living, such as eating, bathing, walking, and dressing. And nearly 30% of Ultimed's enrollees have Alzheimer's or related dementia. 89% are from racial and ethnic minority groups, and 75% are monolingual. Ultimed succeeds because it's dedicated to serving the entire patient rather than focusing on one symptom at a time. And as a result, their enrollees have higher immunization rates, lower emergency room and hospital admission rates, and shorter hospital stays than their peer groups. And 97% of Ultimed's participants are able to remain in their homes with the assistance of care from PACE providers. Now, Ms. Wilson, in your testimony, you noted the importance of the interdisciplinary team in the PACE model. Can you discuss how patients with comorbidities, like the majority of patients served by Ultimed, are served by this interdisciplinary team?
Yes, the interdisciplinary team is the heart of PACE. It is a group of 11 professionals, most with advanced degrees, who sit around the table and discuss each and every patient and each and every condition or situation that may come up with that particular patient. And everybody there is a part of the team, an equal partner, including the driver, including the nurse attendant, including the physician, the physical therapist, the dietitian, the master's level social worker, the recreational therapist. All of those people sit around the table and more as is needed. And they make decisions about the person in the best interest of the person, not in the best interest of the finances of the organization, not in the best interest of staff. Sometimes the family best interests also weigh heavily. How will the family deal with the situation that's under consideration? And so the interdisciplinary team is the heart of the program. When I first started becoming involved with PACE, having been in healthcare for many, many, many years, I thought, oh my gosh, think of all the dollars that are sitting around that table every morning. And I didn't really think that that was going to be a good use of many professionals' times. Over the 10 years that we have been providing PACE, I have absolutely changed my mind. It is the heart of the program. It is the reason that PACE is so effective, and it is the reason that it is cost-effective, because the care is given at the level that is needed before there is a major crisis, which necessitates a hospitalization or other very high-cost care and services.
Thank you. Thank you so much. Dr. Jacobson, I wanted to address the issue of mental health disorders and the seniors that are enrolled in Medicare Advantage. Care More Center, a Medicare Advantage provider in my district, developed the Brain Health pilot program in Southern California that sought to treat individuals with dementia-related problems. And this pilot used teams of practitioners, including a neuropsychologist, a neurologist, pharmacist, and dietitian, to educate patients and caregivers about the risks of neurological disorders and how to address them. So the pilot found that the wraparound services had a profound effect, and there was a 55% increase in reported falls and 38% decrease in emergency room visits. But as a former clinical psychologist, I'm particularly interested in the ability of special needs plans to provide coverage and care for individuals with mental and behavioral health issues. You noted in your testimony that about 1% of CSNP patients are enrolled in plans to specifically treat their mental illnesses. What information do we have, if any, about the beneficiaries enrolled in CSNPs and DSNPs for mental illness?
To answer your question directly, we don't have that data. It's possibly something that we could look into, and I'm happy to talk further with your staff about that after the hearing. There are a few things sort of to emphasize in this, though. For example, the CSNP that you mentioned is the one CSNP that focuses on mental illnesses. It's only available in Southern California. That again emphasizes that these plans are not offered across the country. You really need to, it really depends upon where you live in terms of whether you have access to this. We don't know, or at least offhand, as to how many people with mental illnesses are in SNPs overall. One thing to emphasize, though, is we have noticed that people who are under the age of 65 who are on Medicare, many of whom have mental illnesses, are underrepresented in Medicare Advantage plans. And we really don't understand why they're not enrolling in Medicare Advantage plans at the same rate as other Medicare beneficiaries. Similarly, people who are over the age of 85 are also underrepresented in Medicare Advantage plans, many of whom have Alzheimer's. So it really raises questions about what's actually going on in the Medicare Advantage plans, and we need more information as to how they're actually treating mental illnesses and what they're offering the beneficiaries.
The gentlelady's time has expired. Ms. Jenkins is recognized for 5 minutes.
Thank you, Mr. Chair, and I thank the panel for being here. Ms. Wilson, thanks for your testimony regarding the PACE program. In Kansas, just down the street from my Topeka office is Midland Care Hospice. It operates a very successful and growing PACE program. In September of last year, they expanded their PACE program into Wyandotte County, which is in the Kansas City metropolitan area. And they created a new grieving adult support group, and I'm very pleased that they were able to do that. I really admire their work and compassion for their patients and hope that they'll be able to continue growing and offering services to more Kansans. I have a question about the expansion of PACE and your thoughts on that topic. As you can tell from the questions on committee today, many of us represent rural communities, and Midland Care PACE program there in Topeka serves rural counties in the 2nd Congressional District in Kansas. It's a wonderful program that is a real lifeline for many vulnerable seniors and people living with disabilities. I understand that CMS issued a PACE regulation almost a year ago that is still pending. Were there any flexibilities included in that regulation that would encourage PACE programs to expand to rural areas?
Yes, that's one of the priorities for the National PACE Association, is to have that PACE regulation approved. The proposed rule we need to get is out, but we need to have the final rule. It should be ready to go. All the comments are back to CMS, and there are flexibilities, especially for rural areas, and that is being able to use community physicians to be able to change the interdisciplinary team that I mentioned earlier on, so that you don't have to have 11 professionals around the table, that you can have the select few that need to be there in relation to that particular resident or that particular participant and their particular issue. The CMS guidelines that would come out will be very, very helpful to expanding PACE and doing it a lot more quickly. Additionally, the pilot programs that were approved by Congress and are still waiting to be implemented by CMS, that will allow us to reach out and do many more programs and reach many more populations that we currently are not allowed to do. So we are waiting for CMS to pull the trigger, and would be happy to have NPA work with you, Ms. Jenkins, on anything that you might need in order to help your state move forward on some of those issues.
Excellent. We'll look forward in helping you do that. As a follow-up in your role at Leading Age and the National PACE Association, what would have been some of the concerns that you heard from your local PACE program operators and staff regarding the burden of federal regulations or the confusion that a lack of regulation causes on them, and what can we all do to help ease those concerns?
Well, I don't think there's a lack of regulation, ever, at CMS. But the changes in regulations, let me just put it this way. PACE started as a pilot project with Unlock in San Francisco 45 years ago. And because it was a pilot project, there were many, many regulations and requirements imposed upon it to see whether or not it would be reasonable to continue the program. It obviously was reasonable, and 20 years ago, the first regulations came out, and they have been in place now, the same regulations, and it's time to take a look at those regulations and to make the changes. National PACE Association has made recommendations. We have worked with CMS to look at those regulations and to make improvements and changes to help PACE to be able to grow, to simplify the regulations so that PACE programs that might serve Ms. Eva, as was mentioned before, might be able to flourish. And we need CMS to, as I said, pull the trigger. And if you can make a few phone calls to whomever you may know in that department, then that might help them to understand the importance of their work related to the PACE Innovation Act and also the proposed rules.
Thank you. Mr. Chairman, I yield back.
Thank you. The gentleman from California is recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you for holding this hearing, and thanks to all the witnesses for being here. I think this is one of those rare occasions where we found something that everybody on the committee, irrespective of which side of the dais you sit on, agrees. And I think there's plenty of examples of us working across the aisle to try and facilitate ways to ensure that folks can get health care at home. And you see it in some of the telehealth legislation that Ms. Black and I wrote, and there's just a number of examples of that. And the PACE program is right up that alley. So I want to thank you all for what you're doing and the testimony that you're bringing forward. I don't have a PACE program in my district, but I know my constituents would like to be able to expand their access to health care while being in the comfort of their home. And maybe start with Ms. Wilson. Can you talk about some of the hurdles that organizations may face in creating a PACE program and what Congress and/or the administration could do to support the launch process?
Well, first of all, help us to pass those regulations, encourage CMS to pass them. Second of all, the process to start a new PACE program is long and arduous. It's about 2 years. And to develop a PACE site takes about between $7 to $9 million. That includes the upfront costs to develop purchase the program, purchase the land, build the building, outfit the building, and then have the monies on hand, because it takes 1.5 to 2 years in order to break even with the current payment methodology. Those upfront costs are never reimbursed. Those are costs that not-for-profits fundraise for traditionally. The other concern is in starting a new PACE program, there is, CMS came out 1.5 years ago saying that they had a new way for applications to be approved and submitted and then approved. The new way is once a quarter, there is 1 day, 24 hours, when you may submit electronically your application. And if you miss that time frame by 1 minute, then you must wait another 3 months. The time frames that are lost because some consultant didn't get their report in by 2 p.m., so, you know, in California, so that you can submit it by close of business to CMS 5 p.m. back here on the East Coast, is a real challenge. And we are trying to open another site in our area in San Diego, and the biggest concern of all of our staff, in fact, the greatest fear, is they will miss that one day when they, quote, push the button. And if they miss that push the button, that's another 3 months delay. That's costs that we will be incurring for another 3 months, for which we will receive no reimbursement, and we will not be able to open our program. And it will delay the entire program by at least 6 months. That is for a program that's already up and running, and we are just asking for an expansion. Now, if you look at somebody that wants to come to your area and start a PACE program, and they're starting the 2-year journey, if they forget to press that button or miss that date because of a consultant report, then they are going to be delayed, and that is time and money. That is why people don't want to do PACE programs. It's not that they don't want to do them. It is just so onerous to start a new program that it's almost self-defeating. CMS puts up so many barriers to beginning a program that it's incredibly, incredibly hard.
Anyone else like to add anything? Everybody concur? How about qualified personnel, qualified practitioners? Is there difficulty in finding folks?
At a PACE center?
Yeah, or a PACE center.
We hire, on average, at our centers in California, 70 professional, that's graduate level, degreed people, and on average between 25 to 35 entry-level positions. That would be food service workers, care attendants, other positions, day centers, CNAs, et cetera, that perform that level of work. But on average, 70 professional clinical personnel who serve these people on a daily basis.
Thank you. Yield back.
Thank you. The gentleman from Texas is recognized for 5 minutes.
Thank you, Mr. Chairman. I just have a few questions about the Medicare Advantage plan and its growth that's taking place. I have a district that around the Dallas-Fort Worth area, it's suburban Texas, but I have a 30% participation rate of my Medicare eligible. There's 30% of that population is in Medicare Advantage, and that number seems to be growing. I think, Ms. Jacobson, you did a report. I'm working off of some of your work from last year. My question is there any correlation, and yet Mr. Smith over in his district has like a 5% people that participate in Medicare Advantage that are only 5% that are eligible to do it. Is there a correlation between, when you look down through everybody's district, is there any correlation in the participation in these special programs that we're talking about today? Is there a correlation between the participation of in Medicare Advantage in those districts? Are they more prone to have? Mr. Garbello has 60% of his Medicaid eligible people take Medicare Advantage. Is there any correlation between any of those figures as it relates to these special programs?
Yes, there's a correlation, to give a very straightforward answer, because part of why Medicare Advantage penetration and enrollment rate really differs across the country, one of the reasons is due to firm experiences in those parts of the country and just history of managed care in those parts of the country, which really differs across the country. And another reason is payment rates. And both of those reasons would apply to both regular Medicare Advantage plans as well as special needs plans. And it makes sense that the more plans that are offered, the higher enrollment likely is going to be in those areas. So, which we do see that the more plans that are available in an area tend to be areas where enrollment is higher. So, in that sense, yes, you do see more SNPs in areas where you see more regular Medicare Advantage plans. And we have looked at the growth in Medicare Advantage enrollment nationally as well as in different counties. And in many counties where Medicare Advantage enrollment used to be relatively low, it has been growing pretty quickly. But in other counties, you still see pretty low Medicare Advantage enrollment and relatively few plans. So there is quite a difference across the country.
Any other comments?
I completely agree with that. I just wanted to piggyback that just because an area has a strong Medicare Advantage penetration and that leads to greater growth in the special needs plans doesn't mean that Medicaid is able and willing to play ball alongside it. And I think that's a really important point, that in order for these models to really work, you need a robust, SNP market, special needs plan market, but you also need that Medicaid state Medicaid plan to be willing to play with them. And I think that's been one of the real challenges with this model, is that the SNPs have sort of followed Medicare Advantage plans, but not necessarily. Some states, they're like Minnesota, there really is a robust kind of Medicaid side to this market, but that's not everywhere.
And I know we don't have any jurisdiction over Medicaid. Yeah. Is there a correlation between the states that expanded and the participation in these programs?
That is not something that we've looked at, although I would emphasize that it's for Medicare Advantage and for SNPs, it really is a county by county issue. It is not a state issue. So parts of Texas even have relatively low Medicare Advantage enrollment. But obviously other parts of Texas have relatively high Medicare Advantage enrollment. And you see that in many states.
Thank you. Thank you.
The gentleman from Oregon is recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate our having this conversation. Dr. Vendrick, appreciate having you back. I am continue to be quite enthusiastic about the simple logic that you described, some of the work that's underway. I appreciate you giving us some specifics that you think might make a difference to accelerate the progress. And Mr. Chairman, I would hope that this would be an area that we could spend a little more time. As you know, Congresswoman Black and I have had legislation in the last couple sessions. We're fans. We think that this can be advanced outside the scope of some of the things that get us tripped up around here. And I think there's some really powerful evidence that we can help provide better care and bend the cost curve. But there's just one area, Doctor, that I would seek your advice and counsel, because there are questions about the applicability for VBID in very low income populations who aren't involved with a copay. I mean, they can't afford more, or some of them have no cost sharing. Do you think that there are ways that this can be applied in value-based design to be able to get around this, to be able to provide the power of the concept for people who don't have that type of co-payment or capacity to pay more?
So first off, thank you for the kind words. It's happy to be back, and it's a great pleasure to be talking about one of the rare bipartisan healthcare reform ideas. And I appreciate your work and Representative Black's and others on the committee to make this happen. So we have studied the impact of increases in cost sharing, because that's what's largely happened in this country. And it comes as no surprise, and you don't need advanced degrees like my fellow panelists to know that if you make people pay more for something, they'll buy less of it, and poor people are impacted by higher prices than rich people are. So we have focused very, very much on those people with multiple chronic conditions and those who are economically vulnerable, and have basically tried to implore public and private payers, if you can't extend VBID principles to everyone, you should probably extend VBID principles and lower cost sharing to the people who would benefit the most, and those are the sickest individuals and those who do not have economic resources. The good news, as we heard, such as the PACE program, there's been already integration of VBID principles to make sure that those who cannot afford essential services can. That doesn't mean it's happening all over the nation. I think it's particularly germane regarding prescription drugs in this program, and we have focused a lot of our attention on trying to extend this clinically nuanced cost-sharing issue to the issue of Part D drugs. We know that there are a lot of low-income Medicare beneficiaries who are either cutting their pills or taking them every other day or not taking them as their doctor or nurse practitioner prescribed the way they do that. And there has been external influences like patient assistance programs and charity programs to help bridge that gap. It is our hope that if value-based insurance designs are put in place, whether it be for middle income or low income, that those services that are deemed to be highest value would have zero cost sharing, regardless of income, which is the case for many preventive services in Medicare now, much of the credit from this committee. And we are hopeful that as VBID ideas are extended, particularly for those extraordinarily well-established high-value services, to Dr. Gretchen Jacobson's point is, I don't want to get into the areas where there's controversy when there are 20 years of evidence of quality metrics in the Medicare program. Let's start with those low-lying fruits. And if we can't extend them because of fiscal issues to every Medicare beneficiary, then obviously the best place to get a return on investment would be to focus those on the populations who are most likely to achieve benefit, and those are the low-income folks.
Well, I'm hopeful that we won't ignore the areas of controversy, but I subscribe wholeheartedly to the notion, let's start where we can, establish the principles, spread the benefit. Right. But having a sense of how we can develop the nuance for the lower income, where there might be some way of having a more powerful incentive, or some of the nuance through the program administration, if you could lend some thought
I'll just quickly say that not being a legislator or a lawyer, not understanding all the regulations. In the commercial sector, where the VBID experience is much better studied and wider implementation, there are public and private employers that are extending greater subsidies to employees who are, say, hourly compared to salary. There is
I understand. I just would like your reflection at some point about where there is no cost share, very low income, how we can refine perhaps that incentive. Mr. Chairman, thank you. I appreciate the conversation, and I hope that we can dig a little deeper here. This is very helpful.
Thank you. Me too. The gentleman for Wisconsin, Mr. Khan, is recognized for 5 minutes.
Thank you, Mr. Chairman. I want to thank our panelists for your testimony here today. I represent a very large rural western Wisconsin district, and we're kind of proud in Wisconsin for some of the unique pilot SNP programs that we have, especially with the dual eligibles back home. We've got about 26% penetration with MA plans. Those numbers have been going up, even in the large rural area. And I'm a big believer in trying to move the system to a more value, more quality, more outcome-based incentive system, whether it's through delivery system reform or payment reform. And Dr. Vendrick, with the value-based insurance plans out there, just how much more can we be pushing? How quickly, and when can we start bringing this really to capacity so that we start seeing better results at a better price?
Yeah. So I think I appreciate that comment. I think a lot of people were talking about alignment in a different context earlier in the panel. I want to talk about alignment to you as I know you've been pushing for value and caring more about health than cost, even though we have to be fiscally responsible and clinically nuanced at the same time. Most of the major reforms going on in American healthcare, and particularly in Medicare, are these supply side or provider-facing initiatives trying to get clinicians like myself to behave different and better. And I think we've made marginal success in this regard, moving in that direction. We have not done the same for the patient-focused side. We have continued into this kind of one-size-fits-all design. And I think for me, to think the end-all is to find a situation where clinicians, hospitals, SNPs, ACOs, whatever, are aligned completely with the patient. That imagine now, Mr. Kind, I am paid a bonus to get my patients with diabetes to the eye doctor.
Right.
And my patients are in a plan for which they can't afford the deductible to go to the eye doctor for that exam. So my view about alignment is not more these granular issues. Imagine a situation which we are moving slowly in a bipartisan way toward, where both the providers and the patients are aligned over health, understanding that we have to be fiscally responsible in this regard.
Well, we've got, numerous alternative payment methods out there, different pilots. I think one of the best things we created in the Affordable Care Act was a center on innovation, so we can start experimenting in these areas. But is there more? Is there another pilot or something that you envision that the Center on Innovation ought to be setting up and working with in order to move down this path?
Well, I'll stay with the chairman's theme of integration. I think that one is not so much creating new pilots, but getting pilots to think about one another. And since many of you are from rural areas, one of my favorite demos is the Pennsylvania Rural Health Model, which has been taken in a bipartisan way in that state. Again, many rural districts there to try to preserve and protect access to care for many of those individuals who live in those areas, but being fiscally responsible in that way. And this is largely at this early stage a way to deal with hospitals and clinicians there. And they're only just now thinking about how to better engage patients to get care locally when it's best for them, in that rare instance where they have to go to a center of excellence to go elsewhere.
Yeah.
But I want, again, many of these conversations are driven by dollars. And I love your theme of the fact that we have to think about health as well as dollars in moving these ideas.
Mr. Grabowski, you've already mentioned about the importance of greater clinical financial integration, leading to better results in that. I think it's particularly pertinent with the dual SNPs as well, the Medicare and Medicaid overlap in that. What more can we be doing in order to encourage that type of integration of services?
Yeah, I touched on this earlier in my remarks, but I really think pushing on Medicaid, once again, getting beyond simply having these contracts that consist of case management. I really want true alignment there where the Medicaid program is actually working closely, and the plan, the dual eligible SNP plan actually has some control over the finance. It's an truly integrated financial product. Another model that can often work is where the same managed care company has the dual eligible SNP plan and a Medicaid plan, and there's the opportunity to kind of align there. But if they're not kind of at risk for those Medicaid finances, you're not going to get that meaningful financial alignment up top, and that's not going to work on the delivery.
How are we doing overall as far as the collection of data when it comes to quality measurements? Are we getting better?
I think we're getting better, but I think in regards to this population, I think we have a long way to go. We've sort of had a one-size-fits-all model, as Mark just said. That's really challenging because this is a really unique population with really unique outcomes. And the thought that sort of a 70-year-old Medicare beneficiaries who healthy will have the same kind of quality outcomes as a 80-year-old diabetic or an individual with dementia just isn't the case.
Yeah, great. Thank you, Mr. Chairman.
Thank you. Mr. Higgins, you're recognized for 5 minutes.
Thank you, Mr. Chairman. You've all studied the Medicare Advantage program pretty extensively, and about 31% of the Medicare population is enrolled in Medicare Advantage programs. Pretty accurate?
Did you say it's about 1/3 now?
It's about 1/3, so, okay. A little less than 2 million are enrolled in special needs programs. It's about 12% of the Medicare Advantage population. As this population is frail and chronically ill, I presume that consumes a disproportionate amount of the Medicare Advantage dollar. Do you have any estimates as to what was spent on the Medicare Advantage Special Needs Program last year in 2015?
We don't have specific figures of how much. That's not publicly available data of how much specific plans receive.
Well, why wouldn't that, it's a public program. Why wouldn't that be, if we're looking at designs for greater efficiency in the delivery of services and lowering costs, it would seem to me that the amount of money that we spend each year would be readily available, because that would be an important number to either conclude that we're doing well with it or we need to do better.
So in the past, CMS has released some data on the bids of Medicare Advantage plans which would help to get at how much they are paid. The issue is that it's not, the data that's been released is not granular enough for us to look at how much SNPs in particular have been paid. And
Could
even
we
more
safely
so-
assume then that it's got to be a very high number as compared to the rest of the Medicare Advantage population, right?
Yes.
Okay. Medicare Advantage is administered by private insurance companies. Right? How big a player is United Healthcare in the Medicare Advantage special needs plans?
United Healthcare is the dominant insurer and firm offering the institutional SNPs. They also offer many chronic care SNPs.
Is 20 to 25% of the special needs population on the Medicare Advantage program, are they covered by United Healthcare?
A fairly significant portion, yes, are covered by United.
Do you know what's going on with United Healthcare right now? Yeah. United Healthcare is the United States Department of Justice has just joined a lawsuit against United Healthcare for allegedly defrauding the Medicare Advantage program out of hundreds of millions and potentially billions of dollars in each of the last 10 years. When we look at, designing a program to discover ways, value-based insurance design by using financial incentives to promote cost-efficient, high-value, rather than low-value healthcare services, it would seem to me that that is a major issue. As students of the Medicare Advantage program, are you familiar with the details of that investigation and its implications relative to funding that program? I'm not picking on you. I mean,
I'm well aware that the investigation is ongoing.
are the other private insurance companies that are involved in the Medicare Advantage program for special needs, are they also being looked at? Or also defrauding, overcharging the American taxpayers in Medicare Advantage under the special needs program?
I do not know what other companies are currently being looked at that have not been announced. What I would emphasize is the Medicare Payment Advisory Commission, as you may know, has done a lot of work looking at coding intensity.
I understand. This is fraud. This is stealing money from the American people in the Medicare Advantage program. It's a different issue altogether. I yield back, sir.
The gentleman's time has expired. Mr. Meehan is recognized for 5 minutes.
Thank you, Mr. Chairman. And I want to thank you, frankly, for holding this hearing, which I think is really focused on something which is so important, which is this effort to assure that we continue to look for innovative ways to deliver quality care while at the same time looking for ways to hold down costs. And I am moved by a couple of realities. One, the recognition that when we get to the Medicare Advantage population, we've got about 50% that consume about 3% of the costs, and then a very small percentage, 10%, that account for about the other 2/3. So we know we're dealing with a very targeted population to begin with. And what I found actually is sort of heartwarming and is sort of counterintuitive. You would think that Medicare Advantage, it sort of falls disproportionately, that the wealthier you are, the more likely you are to purchase the plans. And yet, to the extent that I've been able to look at it in my own district, they have been, people have taken the time to invest in getting these plans, and not always people of the highest means. So there's an effort on the part of those who want to be consumers of it. But Dr. Vendrick, I want to focus on what your testimony was earlier about this being directed towards the patient, not just specifically the payer. One of the things that we are looking at is legislation that would create more flexibility to prevent chronic illness or improve care coordination, the kinds of things. How do will you speak to that issue of flexibility that you'd like to be able to see so we can deliver to this chronic group and really not just cost savings, but it is quality. It's these people are better off.
Right. So excellent points. So first off, healthcare is very complicated. Who knew, right? So it's been a long-standing fact that a significantly small portion of populations in Medicare and commercial, right, they expend a very, very large part of the healthcare pie. Most of the fabulous innovation that's going on that allows me to better treat these patients, and I congratulate Congress for the bipartisan passage of the 20th Century Cures Act, which allows even a greater influx of innovative funds to allow me to take care of my patients better. So that's all well and good for those of us who are trained to improve the quality and length of life. Almost all of these innovations, with very few exceptions, come at a significant expense, which requires that tension that I prefer you to have than I do, which is we want to do the best for our patients, but we also have to be fiscally responsible, which you mentioned very clearly in the call of this hearing. So as the practice of medicine moves forward at a rapid pace, Star Wars, we have precision medicine, we have genetic medicine. The delivery system, in my opinion, is like the Flintstones, right? So the delivery system has not been able to catch up to the incredible science that we've had. So we have one of two choices. One is that we slow down the innovation in the Star Wars medicine, which I would not advise, or we continue to have conversations like we're having today and have experts like I have to my right to think about ideas that allow us to have the delivery system catch up to the precise example that you raise. And again, going back to 1965, there was this important issue to make sure that every Medicare beneficiary had the same benefit design. I would argue, 2017 and beyond, given that we can't give all things to all patients, that instead of blunt instruments, a much better approach would be one that's individualized, similar to the situation that we heard in the PACE programs.
Actually, this is part of the legislation is to create supplemental benefits for those that are chronically ill, sort of to address that. You think that would go towards the objective that you're articulating?
Absolutely, and again, it's baby steps, but the initial VBID MA demo not just includes services and providers. CMMI was very, very careful to follow advice from this committee to allow the demo plans to extend supplemental benefits as part of the demonstration package. So a broader view.
Thank you for your testimony. Mr. Chairman, I yield back in light of the time.
Mr. Reed, recognized.
Thank you, Mr. Chairman. I was just going to listen today, but Dr. Vendrick, you touched on something, and I want to follow up on my colleague from Pennsylvania on it, looking at it from a beneficiary patient perspective. So one of the things I firmly believe is that people react to their own fiscal condition. If they see money in their pocket, it seems to generate more behavioral change, in my opinion, than other items in this arena. And so, are you aware of any studies that talk about human behavior and the impact that having a carrot approach to this may have a beneficial income on a reimbursement model? You're talking about, in some of your testimony, for example, the diabetics and having foot and eye exams with no co-pays, that type of thing. Yeah, that's a bottom line financial impact to an individual, but do they really see it? And what I mean by that, I'll tell you a story. When I was a kid, I was raised by a single mom, youngest of 12, and every time we went to the bank to pay the bills each month, she would cash her checks to hold the cash and then give it back. Any type of creative, innovative ways that we could talk about in regards to reimbursing patients for seeing and follow-up care, medication adherence? You get kind of I've even had talks with CEOs of different carriers about even giving them a gift certificate for doing that. And they told me that regulations in New York prevented them from doing that, or maybe they're federal regulations. Does that carry any weight, that kind of nominal type of impact on human behavior? Do you think that could change the curve?
So I should bestow a degree of behavioral economics for that. I mean, David and
Amen.
others are experts here on that. So,
Well, let's go to David too after you, but
so
please,
first
from your
off,
patient
the
perspective.
Kaiser Family Foundation has all this information, a lot of good information in the testimony and elsewhere to answer these types of points. I do believe strongly that particularly in the low-income folks that we talked about earlier, that something as low as $1 matters. So I have seen Medicare Advantage patients who are faced with $4 copays for drugs that everyone in the exam room knows will be meaningful changes, but you never want to be in the situation to either pay rent, buy food, or fill your prescription, which is why we argue for these types of things. But I want to make sure, since you brought, it's not all things for everyone. I would like to start with those conditions and those services for which there is no doubt that they should be prescribed and used in those situations, which is where the nuance comes in. In some commercial settings, we have gone beyond free, and we have actually paid people to do certain things like quit smoking or take their prenatal vitamins or other types of things.
And we've seen a positive change.
We do,
right?
but we also have what I call the frozen carrot, that if people are given an advantage in lower cost sharing to do certain things and they don't, they should also be accountable for that
They
behavior
get the
as well.
stick on that side.
So I call it a frozen carrot. I'd rather call it that.
A frozen carrot, very good. David, could you offer on that?
Yeah, absolutely. And you come to Congress and a behavioral economics lecture breaks out here. This is great. As Mark described, I really like these programs. There's been a lot of positive studies. I'm thinking of the work of Kevin Volpe at the University of Pennsylvania, where he's kind of paid patients to take particularly high-value drugs, and it's VBID on steroids, basically, and it's been shown to be very effective in those applications. So I think you raise a really good point, Mark, that accountability is key in these kinds of programs as well. But I do think if there's going to be huge costs to the healthcare system of non-drug adherence here, we want to make certain that we're potentially incentivizing individuals to adhere to their drug.
And would you agree, David, that even $1 would matter to a lot of those individuals, change their behavior to adhere to their medication?
It absolutely does.
You know it does.
I want to say one thing that you may find very interesting as the argument breaks out here. In a large commercial experiment, we offered Americans in really good insurance plans who had heart attacks their drugs to prevent their second heart attack at no cost to them. They only took them 50% of the time. So we need to go beyond financial incentives, particularly the carrot, as you described, communication, literacy, transportation, not just drug reductions and co-pays to make this work. They took it more often than when they had to pay for it, but still we have a long way to go.
Well, I appreciate that. And being new to the subcommittee, I appreciate to continue to learn on this, and I appreciate the opportunity to participate. Thank you, Chairman.
Well, thank you, Mr. Reed. We have about a minute left to go vote, so perfect timing on your part. Dr. Vendrick, Dr. Grabowski, Ms. Wilson, Dr. Jacobson, you guys were outstanding. Mr. Levin and I both were chatting here, and you've really helped bring along the debate as we move to make Medicare more efficient, both for taxpayers and for the patients that you see, Dr. Vendrick. So we appreciate your testimony today. Your answers were very good. Look forward to working with you in the future. With that, please be advised that members will have 2 weeks to submit written questions to be answered later in writing. Those questions and answers will be made part of the formal hearing record. With that, the subcommittee stands adjourned.